Bronchial asthma is an episodic reversible constriction of the tracheobronchial tree due to its hyperactivity towards various stimuli, which can be external or internal stimuli. Bronchial asthma falls under the category of obstructive lung diseases. Obstructive lung diseases include asthma and COPD. Asthma is reversible while COPD is irreversible. In both of these cases, there will be constriction of the tracheobronchial tree. There are two types of bronchial asthma. One is the extrinsic asthma, where 95% cases are seen, and it is the major type of asthma. Other one is the intrinsic asthma, where 5% cases are seen, and it is rare type of asthma. Extrinsic asthma is due to external stimuli or allergens, which includes dust particles, pollens, chemicals, fumes, and fibers. Certain spores like Aspergillus also cause extrinsic asthma, and this condition is called allergic bronchopulmonary aspergillosis. The other external stimuli are the occupational allergens, but their symptoms usually improve on weekends, and domestic allergens like soft furnishings, curtains, and mites. Intrinsic asthma is triggered by internal stimuli, which is the rare type of asthma. In this case, there will be autonomic dysfunction, which leads to parasympathetic overdrive. It can also be triggered due to stress, anxiety, and emotions. These internal stimuli will cause bronchoconstriction. Treatment of choice in these cases are the ipratropium bromide. Pathogenesis of asthma is divided into two phases. One is the early phase, other one is the late phase. The early phase is mediated by type 1 hypersensitivity reaction, where histamine will be released, causing bronchoconstriction of tracheobronchial tree. The late phase is mediated by arachidonic acid metabolism, and the key substances will be leukotrienes, C4, D4, E4, and slow-releasing substances of anaphylaxis. This phase occurs hours after the initial response. The clinical features in people who are less than 35 years include chest tightness, dyspnea or shortness of breath. There will be cough with white sputum production, wheezing, especially in non-smokers, and symptoms variability over time, and predominantly nighttime symptoms. The 70% of cases with asthma are associated with or already have allergic rhinitis, food allergies, skin allergies, drug allergies, and allergic dermatitis. The general physical examination shows tachycardia, there will be increased heart rate, and tachypnea, there will be rapid breathing. On chest examination, the auscultation finding shows decreased air entry on both sides of the lungs. There will be bilateral bronchi heard throughout the chest, but unilateral bronchi may suggest localized bronchial obstruction. The basic investigations are chest X-ray, and it is typically normal. Complete blood count or CBC shows eosinophilia. There will be increased eosinophils. Serum IgE levels will be elevated, which indicates allergy. Sputum examination shows increased eosinophils, presence of Crushman spirals, which are the damaged epithelial cells, and you will see charcot-laden crystals, which are the proteins released by white blood cells. The pulmonary function test or PFTs, the ratio of FEV1 by FVC will be less than 80%, which is an indicative of obstructive lung disease. So we will administer a bronchodilator, which is normally a salbutamol, wait for 15 minutes, and repeat PFTs to assess improvement. If the reversibility in FEV1 is greater than 15%, then it suggests asthma. If the reversibility is less than 15%, it might indicate COPD. On ABGs, the partial pressure of oxygen will be decreased and partial pressure of CO2 will be normal, which is an indication of type 1 respiratory failure. The severity of asthma is assessed based on the frequency of symptoms, nighttime symptoms, interference with activity, and the use of bronchodilators. The classification includes 4 categories: intermittent, mild, persistent, moderate persistent, and severe persistent. Frequency of symptoms shows how often symptoms like wheezing, coughing, or shortness of breath occur. Nighttime symptoms show how often symptoms wake up the patient at night. Interference with activity shows how much the asthma limits daily activities. Use of bronchodilators shows how often the person needs to use medications to relieve the symptoms. Asthma is classified into 4 categories based on severity: intermittent, mild persistent, moderate persistent, and severe persistent. So the treatment plan is based on the severity of asthma and involves a stepwise approach. The steps involve increasing the intensity of treatment as the asthma worsens. In step 1, you will treat intermittent asthma, and the drugs used are the short-acting beta agonists as needed for relief. Step 2 indicates mild persistent asthma. In this case, the drugs will be low-dose inhaled corticosteroids daily plus short-acting beta agonist as required. The other drugs are the leukotriene receptor antagonists, which can be used as an alternative to low-dose inhaled corticosteroids. Step 3 is the moderate persistent asthma. In this case, the low-dose inhaled corticosteroids plus long-acting beta agonists on daily basis plus short-acting beta agonists as required. Leukotriene antagonists can be added to inhaled corticosteroids for patients with aspirin-exacerbated respiratory disease. Step 4 is the severe persistent asthma. In this case, there will be high-dose inhaled corticosteroids plus long-acting beta agonists daily plus short-acting beta agonists as required. Now, leukotriene antagonists or theophylline can be added. Step 4 is the severe persistent asthma. In this case, high-dose inhaled corticosteroids plus long-acting beta agonists daily plus short-acting beta agonists as needed plus leukotriene or theophylline can be added, and oral steroids for a limited time, normally 2 weeks for severe exacerbations. So the initial treatment plan should be tailored to the severity of the asthma. GINA guidelines recommend that all asthma patients should start with step 1 medication, which typically involves short-acting beta agonists as required for quick relief. The goal of asthma management is to achieve and maintain good asthma control. This means having minimal symptoms, no nighttime awakenings, and no limitations on daily activities. After 2 weeks of starting the initial treatment plan, the patient should be evaluated. This assessment will determine if the treatment is effective and whether any adjustments are needed. During the follow-up, the healthcare provider will assess the patient's asthma control based on symptoms, lung function tests, and other relevant factors. If the patient's asthma is improving, the current treatment plan can be continued for 3 months. After 3 months, the healthcare provider may consider stepping down the treatment to lower dose or less intensive regimen if the asthma remains well controlled. If the patient's asthma is not improving or is worsening, the treatment plan will need to be stepped up to a higher dose or a more intensive regimen.